Trying to ask to review manuscripts, Dr. Veith. You'll be happy to hear that my 3-year term was up last December, and I tried to resign, actually submitted my letter of resignation, but Tony and Bruce, they got an extra 1.5 years on, and they wouldn't accept it because they said they had finally trained me and they weren't going to give me up. So only a little bit longer while you keep getting the requests. I am here, although I've used obviously the letterhead, I am here totally in the unofficial capacity. The management knows that I'm here because I've asked them for information, but anything I say is my own opinion. I'm not sanctioned to be here. Opinions are entirely my own, as you'll see. So what I do, so last year when I gave a discussion about this, I had a very organized approach, and those of you who know me realize that's the way I like to do things. I had a nice list. I got from Jessica Brabant, the managing editor, the list of the 20 most downloaded and most cited articles for 2013. I looked at both lists. I chose the best for each of those, made sure that they had an endovascular bent to them. Actually, the last 4 months there wasn't very much data, so to be fair, I used a little bit of my own data. And this year, I threw it all away and just basically used my own bias about what I thought was helpful and important, with the caveat that it did have to have some endovascular component to the article, which was important for this group. So the very first one, published in January, the Society of Vascular Surgery Threatened Limb Classification System Risk Stratification based on wound ischemia and foot, or Wi-Fi, led by Dr. Joe Mills, which this is a passion of his. The question that was asked, can the classification system for critical limb ischemia be improved to account for 2 other significant contributors to limb loss? That is foot infection and wound extent. And basically the design of this study, if you want to call it that, was a consensus by members of the Society of Vascular Surgery Lower Extremity Guidelines Committee. A consensus, of course, is something agreed to by everybody and believed in by no one. The setting was all practices treating patients with critical limb ischemia of the legs. And they noted there were sort of some existing, the 2 major existing ischemia grading system were the Rutherford classification, and if you kind of look at Rutherford 4, 5, and 6 is what we're mainly most interested in, that is ischemic rest pain, minor tissue loss, or extensive foot gangrene, and the Fontaine system 3 and 4 being the same. There are some existing ulcer and or wound as well as infection grading systems that have been described before, but as the consensus met, they decided that none of these were really adequate. So they came up with this, again, Wi-Fi. So the W for Wi-Fi stands for wounds, and there were 4 subgrades as there are going to be for each of the 3 components. And you can see the description is a little bit different depending on whether it's an ulcer or gangrene. And the higher the number, the worse it is. Same thing for ischemia. Now it's not really clear to me if you have someone who has an ABI of 0.65 and yet their ankle systolic is 55 and the toe pressure is 29, exactly where they fall, but I think that would probably fall in grade 1. In any event, realizing also that sometimes we can't always tell with non-compressible vessels where they are. And then finally, the Phi stands for foot infection, and again, for, the various grades, progressive would mean no evidence of infection all the way to requiring a systemic Sears response, inflammatory response syndrome. And then they put it all together in this table that you can see and sort of grading ischemia across the wound level and the presence of foot infection. And green is good, so very low, clinical stage 1 for the risk of amputation, and then meeting the consensus came up then with the red being the clinical stage 4. And again, the primary purpose of this is I think to help us evaluate studies that are out there, because critical limb ischemia is not critical limb ischemia. It's not critical limb ischemia, and a lot of different presentations come across. The secondary thing that they looked at was trying to estimate the likelihood benefit from revascularization. And again, you can see that probably not not much benefit if you have little ischemia, minimal wound, or minimal foot infection, whereas getting to the further degree is much more likely to benefit from some kind of revascularization. So at least in my own practice, I've started trying to grade the individual patients to sort of see how helpful it is. The group from Greenville, Dr. Langen's group, has already published a paper validating this system in the journal. So their conclusion was that implementation of this classification system tended to permit a more meaningful analysis of outcomes for various forms of therapy in this challenging population, and I would come to the same conclusion. Moving right along, it was published in April, Complications of Indwelling Retrievable versus Permanent Inferior Vena Cava Filters by Desai and the group from Illinois. And their question that they asked was, is the long-term safety of indwelling retrievable inferior vena cava filters comparable to that of permanent inferior vena cava filters? My partners are probably smiling or laughing or wringing their hands right now because they already know my strong opinion of this, but in any event, the design was a retrospective cohort study at a single institution. The setting was a university-affiliated medical center. All patients undergoing placement of inferior vena cava filter from January 2005 through December 2010. And from this, there were initially 449 retrievable filters placed, of which 383 or 85% were left in place. They compared those to 785 permanent filters that were placed along the way. And so basically intervention comparing retrievable to permanent filter in terms of performance. The primary outcome interest was symptomatic complication, whether it be thrombosis, pain and perforation, fracture migration, or perhaps systemic complications including death. Secondary outcomes were pretty much the same thing, only those being that were asymptomatic. The results are as followed. Ultimately, in the analysis, you'll see that because the event rate is relatively low, that I think there are a number of type 2 errors, that there may be a difference, but it's not found to be clinically significant. But when they group all device-related complications for symptomatic and asymptomatic, you can see that is a difference by a factor of 10, being much more likely with the retrievable filters left in place. Complications, again, you can see and the various kinds of complications, again, on the far right, you see none of those are, with the exception of grouping them all together, are statistically significant, but the event rates are higher for the retrievable versus the permanent sutures. If you look at the nice Kaplan-Meier curve, freedom from complications overall, up through 7 years. And also freedom. They actually did another thing, is they propensity matched those patients who had indwelling retrievable filters, trying to do a little bit better job of retrospectively trying to look from the same group of patients, and they found that there continued to be a difference between the retrievable filters left in place versus the permanent filters. Their conclusion, which supports my pre-existing bias, is that indwelling retrievable filters are associated with an overall higher complication rate compared with permanent filters, with thrombotic complications representing the most common complication from both types of filters. Therefore, retrievable filter use should be limited to patients with appropriate indications in whom retrievable is highly likely, and systemic follow-up of those patients with retrievable filters is necessary to improve current retrieval rates. The third study that I chose, and by the way, I only chose 5, so we'll get to hear Dr. Guillermo's in here in just a minute, was from May, a multi-center randomized controlled trial of totally percutaneous access versus open femoral exposure for endovascular aortic aneurysm repair, or the PVAR trial, led by Dr. Nelson, but of a multi-institutional trial. The question they asked was, is endovascular aortic aneurysm repair performed totally percutaneously as safe and effective as repair with standard open femoral exposure? This was a prospective, randomized, FDA-approved trial. The setting was in 20 different U.S. centers with prior experience with PVAR. The patients were all patients with an aneurysm at least 5 centimeters in size or rapidly expanding, who did not have significant renal insufficiency, and you can see required at least 2 centimeters of common femoral access available, no calcification at the site, and that they could be accessed at least 1 centimeter above or the deep femoral or 1 centimeter below the external iliac. They had no prior groin incision, scarring, or hematoma, no prior clip closure ever, or if they'd had a collagen closure system used within 90 days, they were ineligible, and they had not had any femoral access in 30 days. The interventions, actually 3 different interventions in equivalent amounts. So an endovascular with percutaneously closed with a Perclose ProGlide, with a ProStar XL, or with standard femoral exposure. And ultimately that led, of course, to a 2-to-1 ratio of PVAR to EVAR. One of the restrictions of the system was that all of these patients underwent or were treated with the Endologix endograft system, so it may or may not be generalizable to others. In any event, the primary treatment success was defined as procedural technical success, absence of major adverse event or vascular complication at the 1-month interval. And their secondary outcomes were major ipsilateral access site vascular complications, time to hemostasis, time to ambulation, and resumption of normal diet. This is their figure cartoon looking at the randomization status. And what we can see is that most of the patients were available for evaluation at the 1-month interval, slightly fewer at the 6-month interval. The results are as follows. You can see that both with the ProStar and the ProGlide, it was successful the vast majority of times, with cut down necessarily a minority of times. Obviously, the incidence of cut down, since the comparison group was cut down, you can obviously there's a statistically significant difference in those groups. Otherwise, the differences really are not statistically significant. If you look the bottom half of the slide, you can see what they did with the opposite side. This study was designed just to look at one side, not both sides, and not quite sure why, but actually there seemed to be some pretty significant differences about what one did with the opposite side, and I don't think there was any good explanation for that. Overall fluoroscopy time, estimated blood loss, and blood transfusion, the differences which occurred were not significant. What was different was that it took longer, on average over a half an hour longer, to do a femoral exposure and then closure as it did with the percutaneous closures. Time to ambulation, time to resumption of diet was not different. Interestingly, there was the differences in terms of the failure of treatment between the ProGlide and the open femoral artery exposure were significantly different. They were not different with the ProStar. On the other hand, procedural technical failure was significantly higher with the ProStar than it was with the open femoral exposure. The rest of the differences are not significantly different. If they looked at the grading system for ipsilateral groin pain, you can see that, in fact, the highest pain, I guess this is not really surprising, but the level of pain was highest with the femoral exposure at just before discharge, and compared with the ProStar, although interestingly not with the ProGlide, that difference persisted through the first month. But as you would hope and expect, by 6 months, there really was no difference in terms of ipsilateral groin pain. Patient survival differences were not statistically significantly different. So the results, no difference, also interestingly, in the SF-36 quality of life and the physical or mental health dimensions between the two. There were significantly more analgesics used in the femoral exposure than either the percutaneous methods. Again, probably the fact that the difference between femoral exposure and ProGlide were probably a type 2 error due to the limited size. The conclusion was that among trained operators, PVAR using the 8 French Perclose ProGlide was as safe and effective as open femoral exposure. The study was, however, underpowered to achieve non-inferiority of the ProStar system compared with open femoral exposure, although the event rates for both, for the most part, were similar. The fourth study I wanted to talk about appeared in June, and that was Solastazole is associated with improved outcomes after peripheral endovascular interventions by Warner et al. Leading the group. This is actually looking at the New England Vascular Group. Their question was, does oral Solastazole reduce the risk of adverse outcomes after peripheral endovascular interventions? The design was a meta-analysis of published trials of Solastazole in combination with antiplatelet therapy compared to antiplatelet therapy alone. And from this, after initially searching the literature, they came up with 2 prospective randomized studies and 4 retrospective cohort studies. The setting was not specified. The patients were all endovascular for infrainguinal disease. All the study comparisons must use Solastazole, and the comparison must either be an antiplatelet therapy, placebo, or none, minimum of 6 months follow-up, and at least one of the pre-specified outcomes of interest. The intervention, again, was the use of Solastazole. The primary outcome interest was the post-intervention restenosis rate, and the indications for restenosis were a velocity ratio of greater than 2.4 or more than 50% diameter loss. Secondary outcomes that they looked at were the freedom target lesion revascularization, patency, amputation-free survival, and limb salvage. Again, this is sort of the diagram of how they winnowed things down. They started out with initially 565 records identified by the database, and ultimately got that down to only 6. If you look at the outcome of restenosis after peripheral vascular intervention, there was a statistically significantly lower risk of restenosis in patients who were treated with Solastazole in all 3 studies. When the studies were pooled together, that not surprisingly difference remained. There was a statistically significantly better limb salvage in favor of Solastazole. There was a significantly better amputation-free survival with patients who received Solastazole therapy, and there was a statistically significantly better freedom from target lesion revascularization with Solastazole from these studies. The mortality differences were not significant, either when looking only at the randomized controlled trials or the cohort studies. So their conclusion, and one that I would support from their study, is that the addition of Solastazole to antiplatelet therapy after peripheral endovascular intervention is associated with a reduced risk of restenosis, amputation, and target lesion revascularization. I found this study to be very interesting, and had been personally totally unaware of the strength of that conclusion. The final study, just to kind of keep in a little bit of the broad area of vascular interventions, this was a prospective randomized study of cutting balloon angioplasty versus conventional balloon angioplasty for the treatment of hemodialysis access stenosis. Appeared in September. There's a group from Cairo. The question was, is cutting balloon angioplasty superior to standard balloon angioplasty in the treatment of hemodialysis access stenosis? So this was a prospective randomized non-blinded intention to treat analysis. The setting was at tertiary referral centers in the Middle East. All patients undergoing treatment of greater than 50% stenosis of their hemodialysis access fistula and graft. A number of exclusion criteria. The interventions, again, either conventional or cutting balloon angioplasty. The primary outcome they chose was assisted primary patency, and the results as followed: that the initial clinical success, there was no difference, with the possible exception is you look at residual stenosis. Interestingly, there was a higher degree of residual stenosis with the cutting balloon in the intragraft type of stenosis. So they looked at stenosis lesions, venous lesions only, graft to vein anastomotic lesions, intragraft lesion or arterial anastomotic, and interesting was the intragraft lesions. If you look at overall, again, their primary outcome of interest, assisted primary patency, the differences that you see did not attain statistical significance. Although it appears, at least on the venous end, that there may be a trend better with the cutting balloon. The only one that found a statistically significant difference was in the graft to vein anastomosis, in which case the cutting balloon angioplasty worked better than the conventional angioplasty. So their conclusion, which is supported by their data, is that cutting balloon angioplasty is associated with a greater assisted primary patency at 1 year than conventional balloon angioplasty for the treatment of graft to vein anastomotic stenosis. No differences in patency were noted for the treatment of venous, intragraft, or arterial anastomotic stenoses. So finally, that's my opinion of the best papers published in JVS during the last year. I'm sure many of you had your other opinions of perhaps more important papers. I'm sure that my own bias about the management of peripheral vascular disease led to my selection of these, and there you have it. Thank you very much.
That's great. So can we ask any questions?
Sure.
What dose, the 50 or the 100 milligram dose of Clouse, and is this indefinite or a period of time?
So they didn't look at how long it would go. It was only during the course of the study. It would seem reasonable to assume that the benefit would continue over time, although clearly in other instances, if you know, some of the initial, because some of the factors that incite intimal hyperplasia continue forever, differences in graft compliance and arterial compliance and things, although you would assume that perhaps the greatest effect would be earlier on. And I believe that they didn't really go into the individual studies about what was there, but I believe the initial intent was to use 100 milligrams twice a day for lysosol. Questions I would like to ask or find out more about myself would be, number one, what about those patients? Because there seems to be a significant number of patients who just don't tolerate it, not only for the GI upset, but also, you know, anxiety, nervousness, and even, you know, palpitation and tachycardia. And secondly, large part of my population, my practice is in the VA, and it's you have to promise an arm and half a leg to be able to get patients onto Pletol. I'm not sure about insurance coverage because I don't know that in the absence of ongoing claudication that's really considered an indication for the drug. Dr. Veith.
Those were excellent reviews. Can you explain why the temporary IVC filter results were worse than the permanent? Basically, the devices are the same.
Well, I think that there are differences. Some of the earlier devices, of course, when you had the double cone, it was different. By the way, Dr. Greenfield trained me, and I've always been a very outspoken proponent of his filter, having seen them in use. But you know, I think a lot of it has to do with the kind of fixation and along the vein wall that most of the temporary filters, in my opinion, have a much broader based kind of fixation to allow them to be able to then be removed, that they depend more on friction than necessarily a perforation of the vena cava. And I think it's probably that fixation up above the vena cava is, in my personal impression, why there's a difference. Obviously, the cone nature of the filters, I think that's extremely important also, and the cone has to be pointed in the right direction to allow the filters to be self-cleaning. Thank you.